ഹലോ എവരി വൺ. ഇന്ന് നമ്മൾ സർജറിയിലെ കുറച്ച് ഇമ്പോർട്ടൻറ്റ് ടോപ്പിക്സാണ് പഠിക്കുന്നത്. അപ്പോൾ സർജറി അസിസ്റ്റൻറ്റ് സർജൻ്റെ സിലബസ് നോക്കുകയാണെങ്കിൽ വളരെ കുറച്ച് ടോപ്പിക്സ് മാത്രമേ നമുക്ക് ഇതിൽ സിലബസിൽ പഠിക്കാനുള്ളൂ. നമുക്കിതിൽ നിന്ന് ഒരു 14 മാർക്സിൻ്റെ ക്വസ്റ്റ്യനാണ് വരുന്നത്. അപ്പം ഇതിൻ്റെ സിലബസിൽ നമ്മൾക്കുള്ളത് ട്രയാജ്, അക്യൂട്ട് പാൻക്രിയാറ്റൈറ്റിസ്, പിന്നെ സ്യൂഡോസിസ്റ്റ് ഓഫ് ദ പാൻക്രിയാസ്, ഫ്ലെയിൽ ചെസ്റ്റ്, എക്സ്ട്രാ ഡ്യൂറൽ ഹെമറേജ്, സബ് ഡ്യൂറൽ ഹെമറേജ്, ഗ്ലാസ്ഗോ കോമ സ്കെയിൽ, കമ്പാർട്ട്മെൻറ്റ് സിൻഡ്രോം, carcinoma breast, varicose vein, hydatid cyst, gangrene, dry and wet, diabetic food grading and management, non-healing ulcer, causes and evaluation, lipoma, carcinoma oral cavity, stages of TB lymphadenitis, bronchial cyst, acute abdomen. അപ്പോൾ ഇത്രയും ടോപ്പിക്സ് മാത്രമേ നമ്മൾക്ക് സർജറി സിലബസ് നോക്കുകയാണെങ്കിൽ നമുക്ക് പഠിക്കാനുള്ളൂ. അപ്പോൾ അതിൽ ഉള്ള കുറച്ച് ഇമ്പോർട്ടൻറ്റ് ടോപ്പിക്സാണ്, അതിലുള്ളത് മാത്രം സിലബസ് ബേസ്ഡ് ആക്കി മാത്രമുള്ള കുറച്ച് ടോപ്പിക്സാണ്. കാരണം എക്സാമിന് ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള ടോപ്പിക്സാണ് നമ്മൾ ഇന്ന് ഡിസ്കസ് ചെയ്യുന്നത്. ആദ്യം ട്രയാജ്. First is the red category. Red category requires immediate care. So this patient who have life-threatening injuries, so they require treatment within a minimum amount of time, that is within a 1 hour. If we are treating this patient, there is a good chance of recovery. Yellow is urgent care. So here treatment can be delayed for a limited period of time, but in red we cannot wait. They require immediate treatment. Then there will be good chance of recovery. In yellow we can delay it for a limited period of time without significant mortality or in the ICU setting. For whom life support may or may not change their outcome given the severity of their illness. Green are delayed. They require only delayed treatment. Even though if their treatment is delayed, they are not going to die. They are walking wounded patients. They will have only mild laceration, abrasion or mild wound. Okay. Next is blue. This requires expectant management. So patient who have injuries requiring extensive treatment but that exceed the medical resources available in the situation for whom life support is considered futile. Next is black is dead patients. Okay. Flail chest. It is the fracture of 2 or more consecutive ribs at 2 or more places. So here the clinical feature is paradoxical chest wall movement, which means when the patient is inspiring, the flail segment that will move inward, and when the patient is expiring, the flail segment will move outward. This is the paradoxical chest wall movement. Management is initially we will give O2 and just pain management only. We will give analgesia. If this is not sufficient, then we will go for IPPV, that is intermittent positive pressure ventilation. If this is also not sufficient, then we will go for a surgical fixation. Next topic is brain hemorrhages in the brain. We have to learn extradural hemorrhage and chronic subdural hemorrhage. Extradural hemorrhage, this is common in young patients, and subdural hemorrhage is seen in elderly patients. In extradural hemorrhage, it is due to high velocity impact. There is middle meningeal artery rupture. Most common site is the pterion or the temporal region. In chronic subdural hemorrhage, it is due to venous bleed. This is due to bridging veins. The bleeding from the bridging vein. This is not restricted by any sutures. In EDH we have lucid interval. In EDH we have lucid interval. And in SDH we have gradual altered sensorium. In EDH, we remember as EDH, idli have convex shape at edges. So this is also biconvex shape. This is also biconvex shape. Then in SDH, the opposite, that is concave shape or crescentic hemorrhage. They are concave or crescentic hemorrhage. And the treatment for both is Burhole or craniotomy. Okay. So in EDH is for young patient. EDH is having lucid interval and there is biconvex hemorrhage and the artery is middle meningeal artery. SDH, elderly patient, there is bleeding from the bridging vein and there is concave or convex shaped hemorrhage or crescentic hemorrhages, and the management is Burhole or craniotomy. So this is a VVIP topic, Glasgow coma scale. This is very important. So we have 3 things: eye opening, verbal response and motor response. Eye opening, spontaneous 4, to sound 3, to pressure or pain 2, none 1. For everything none is 1. Okay, for everything none is 1. Next, for verbal response, patient may be 5, patient oriented, 4, confused, then in 3, abnormal word, in 2, abnormal sound. Okay. Next is motor response, patient will 6, patient will obey commands, then 5, localized to the pain, that is normal flexion, normal withdrawal flexion from the pain, that is 4. Then 3 is abnormal flexion, 2 is abnormal extension. The minimum score is 3. So You should remember that the minimum score is 3. It is not 0. It is 3. Okay. And the maximum score is 50. Okay. Minimum is 3 and maximum is 15. This is very important. Next topic is acute pancreatitis. The pathophysiology of acute pancreatitis. It is a theory of co-localization, that is, there is activation of the pancreatic enzyme within the pancreas. So there will be autodigestion and there will be inflammation of the pancreas. The causes of the pancreatitis. There is a mnemonic, that is I get smashed. Here I get smashed. I is idiopathy. G is gallstone. This is the most common cause of the acute pancreatitis. Ethanol, trauma, steroid. M is mumps, then Epstein-Barr virus, cytomegalovirus. A is autoimmune. S is scorpion sting. Then H is hypercalcemia, hyperlipidemia, hypothermia. Okay, and hypertriglyceridemia. E is ERCP. D is drugs like steroids, sulfonamides, azathioprins, NSAIDs, diuretics. Here the most common is the gallstones. That is, I get smashed. Okay. Next, clinical feature is epigastric pain. Here the epigastric pain, this is radiates to the back and it is relieved by bending forward. So here the pain is radiating to the back and it is relieved on bending forward. Then second is in acute hemorrhagic pancreatitis, there is Cullen sign and Gray Turner sign. In Cullen sign, there is discoloration around the umbilicus, and in Gray Turner sign, there is discoloration in the flanks. Okay, in Cullen sign, U for umbilicus, it is in the around the umbilicus, and in Gray Turner sign, it is G and F. Okay, G, F, it is in the flanks. Next, investigation, lab investigation. Here salivary amylase and salivary lipase. Salivary amylase is the most sensitive and salivary lipase is the most specific one. Then in X-ray there is colon cutoff sign, sentinel loop sign and gasless abdomen. Okay, there is colon cutoff sign, sentinel loop sign and gasless abdomen. And investigation of choice is CECT. We are doing CECT only after 72 hours. Okay. Next is that for assessing the severity, we have Glasgow criteria, Ranson's criteria, BISAP score and CT severity index. Here I am going to teach you Ranson's criteria. So here there is a mnemonic for on admission and on within 48 hours. So on admission we have Gallo. G is glucose greater than 200. Then A is age greater than 55 years. L is LDH greater than 350. Then AST greater than 250. And W is WBC count is greater than 16,000. Okay. Then here, this is the within 48 hours we have Ka-Hops. This is the mnemonic. Ka-Hops. C is Ka is calcium. Calcium is less than 8 milligram per dl. Then H is HCT drop, that is greater than 10%. O is O2 less than 60 mmHg. B is, we have two B's. One is bun rise, that is greater than 5 milligram per dl. Then base deficit, that is greater than 4 milligram per milliequivalent. S is fluid sequestration, that is greater than 6 liter. Okay, so Gallo and Ka-Hops. Okay. Next, coming to the complications of the acute pancreatitis. Systemic complications are SIRS, that is systemic inflammatory response syndrome. This is due to increased vascular permeability from the cytokines. Okay, then hypoxia, hyperglycemia, there is hypocalcemia. This hypocalcemia is due to there is fatty necrosis. Due to this, there is sequestration of the calcium and there is fall in the ionized calcium. Hypocalcemia. Reduced serum albumin. Next, there will be pancreatic necrosis, pancreatic abscess, pseudocyst and pancreatic ascites or pleural effusion. Then there can be upper GI bleeding, then variceal hemorrhage due to splenic or portal vein thrombosis. Okay, then duodenal obstruction and obstructive jaundice. So these are the important complications. Coming to the management. The management is, we have to immediately resuscitate the patient. We'll do aggressive IV fluid. The most commonly we are giving Ringer lactate. In oxygen, we have to maintain SpO2 greater than 95%. Then we have to do pain control. Nutrition. For mild pancreatitis, we will start oral feed once the pain decreases. For moderate to severe pancreatitis, we will give enteral feeding within 24 to 72 hours. Prophylactic antibiotics, we are not giving antibiotics prophylactically, but in case of infected pancreatic necrosis or cholangitis or sepsis, in these cases, we are giving antibiotics. We are giving carbapenems or fluoroquinolones and metronidazoles. Okay. Next is specific management based on the etiology. Gallstone pancreatitis, we are doing ERCP within 24 hours if there is cholangitis or persistent biliary obstruction, or we will do cholecystectomy. Management of the complication. Pancreatic necrosis, if it is sterile necrosis, we will do conservative management. If it is infected necrosis, then we will give IV antibiotics. Then percutaneous drainage or endoscopic drainage, minimally invasive necrosectomy. Open necrosectomy if this minimally invasive necrosectomy failed. Pseudocyst, this is very important. The pseudocyst is a false cyst. It is a false cyst as it is lined by a granulation tissue. The most common site is the lesser sac. The clinical feature is there will be a epigastric mass. The patient comes with nausea and vomiting and decreased appetite. Here the investigation of choice is CECT. Most this pseudocyst will resolve spontaneously. If the size is less than 6 cm and the thickness of the wall is less than 6 mm and it is less than 6 weeks, then we will need only observation. If it is greater than 6 cm or if it is greater than 6 mm thickness of the wall or it is greater than 6 weeks, in that case it requires drainage. We can do external drainage or internal drainage. We are doing external drainage for infected cyst. It is contraindicated if there is communication with the pancreatic duct. Internal drainage is cystogastrostomy or cystojejenostomy. Okay. So this is about the acute pancreatitis. Okay. Next topic is compartment syndrome. In compartment syndrome, there is increase in pressure in a closed osteofacial compartment. And this will lead to decreased capillary perfusion and there will be muscle and nerve ischemia. The compartment pressure will rise greater than 30 mmHg. Causes are most commonly it is traumatic. Fracture of the tibia is the most common cause. Then may be due to crush injury or reperfusion injury. Non-traumatic is due to splint. Tight cast or tight splint, then burn slip in a scar, snake bite, vigorous exercise or bleeding disorders. Clinical features there is 6 P's: pain, paresthesia, pallor, pulselessness, paralysis. Here pain is the earliest clinical feature and the very late one is the pulselessness. Late is the paralysis. Okay. Its immediate complication is muscle necrosis, nerve damage and kidney failure, that is myoglobinuria. Delayed is the Walkman ischemic contracture, chronic pain, sensory loss and infection. In Walkman ischemic contracture, the most commonly affected muscle is the flexor digitorum profundus rather than flexor pollicis longus. So here the most common muscle involved is the flexor digitorum profundus. Okay. Breast cancer is a very important topic. Okay, coming to the risk factors of the breast cancer. First is increasing age and increasing estrogen conditions like early menarche and late menopause, nulliparity, then smoking, obesity, alcohol. Family history, hormonal replacement therapy like estrogen and progesterone. Then maternal age at first live birth is greater than 30 years. Next is the most common quadrant. The most common quadrant affected is the upper outer quadrant. This is very important. So the most common quadrant is the upper outer quadrant. So this quadrant is the most common quadrant affected. And the most common type of breast carcinoma is the invasive ductal carcinoma. Here we have a triple assessment. In triple assessment, first one we are looking is history, taking a clinical examination. Then we will do radiological investigation and histopathological investigation. In radiological investigation, we will do USD and mammography. In histopathological investigation, we will do FNAC and biopsy. Here in the radiologically, less than 40 years, we are doing USD. Greater than 40 years, we are doing mammography. Okay. Luminal A. Luminal A is the most common variety and it is the best prognosis. This is the most common and best prognosis. Here ERPR is positive. Here ERPR is positive and there is HER2 negative. Okay, ERPR positive, HER2 negative. Luminal B. Luminal B is ERPR positive, HER2 positive or HER2 negative. ERPR positive, HER2 positive or HER2 negative. Here luminal A is the most common and best prognosis. HER2 enriched, here only HER2 is positive. ERPR is negative. ERPR is negative. Basal like or TNBC. TNBC means triple negative breast carcinoma. Here all are negative. Here ERPR negative and HER2 also negative. Then we have unclassified or Claudin law. This is also a triple negative. Okay. In basal type, there is firstly there is good prognosis with chemotherapy. But the problem is here there is a greater chance of recurrence in basal like TNBC, and it has the worst prognosis among these. Next is the staging. Okay, in the staging we have TIS is ductal carcinoma in situ. Okay, then T1 is less than 2 cm, T2 is 2 to 5 cm, and T3 is greater than 5 cm. Next is the T4. T4 we have T4A, T4B, T4C and T4D. T4A there is chest wall involvement except pectoralis major muscle. T4B there is skin involvement. There will be pudy orange appearance, then ulcerations and satellite nodules. T4C is for A and for B. T4D is inflammatory breast carcinoma. There will have typical skin stage involving greater than 1/3 of the breast, and there will be pudy orange appearance of. This is the T4 staging. Next is the coming to the N1. N1 is the ipsilateral mobile. It is the ipsilateral mobile. Ipsilateral mobile. N2A. Next is the N2A. N2A is ipsilateral fixed axillary lymph node. Fixed or mated axillary lymph node. N2B is, then we are coming to the internal mammary. Okay, ipsilateral internal mammary without axillary. This is without axillary involvement. N3A is ipsilateral infraclavicular. Firstly, we are coming infraclavicular. N3B, this same as N2B, but here ipsilateral internal mammary with axillary lymph node. N3C is supraclavicular. Okay, supraclavicular. So N1 is ipsilateral mobile. Then N2A, N2B. N2A is ipsilateral fixed axillary lymph node. N2B is internal mammary without axillary. N3A is infraclavicular. N3B is ipsilateral internal mammary with axillary lymph node. N3C is ipsilateral supraclavicular lymph node. Okay, coming to the management. First of all, this early breast carcinoma recur MR, that is BCS, that is breast conservation surgery. If we can't do breast conservation surgery, then we will go for a modified radical mastectomy. LABC is any stage T3, any T3N1 or any T4, any N2, N3. Okay. T3N1, any T4, T4N1, T4N2, T4N3, any T4 or any N2, that is T1N2, T2N2, T2N3, T1N3, any N2 or N2, N3, that is local advanced breast carcinoma. In locally advanced breast carcinoma, first of all we will do what? First of all we will do neoadjuvant chemotherapy. Then we will do MRF and then we will do radiotherapy. So first we will do neoadjuvant chemotherapy, then modified radical mastectomy, then we will go for a radiotherapy. Chemotherapy we are doing for LABC, then that is locally advanced carcinoma. Here see, in LABC we are doing chemotherapy. Then lymph node positive cases and triple negative or ERPR negative or HER2 positive. Here ERPR, all ERPR case negative cases only we are doing chemotherapy, or HER2 positive or triple negative cases. HER2 positive we are giving trastuzumab. Okay. Next is the radiotherapy. Radiotherapy for we are giving for this LABC lymph node positive cases and tumor that is greater than 5 cm, and we are giving after PCS. Okay. Hormonal therapy, ERPR positive cases. If it is postmenopausal, we will give letrozole, and if it is premenopausal, we will give tamoxifen. Tamoxifen is, that is selective estrogen receptor modulator. Then letrozole is aromatase inhibitor. Okay. Then contraindication of the BCS. So BCS is, that is breast conservation. This is contraindicated in pregnancy if there is prior radiation therapy to the chest wall, collagen vascular disease, multicentric disease, multifocal disease, multicentric and multifocal, lobular cancer, or large tumor breast ratio, or locally advanced breast carcinoma. If there is contraindication, then we will do MRI. Okay. In BCS, after the surgery, we are doing this radiotherapy. Okay. Complication of MRM is hemorrhage. There can be hemorrhage, then there can be injury to the nerve. If there is injury to the intercostobrachial nerve, then there is numbness and paresthesia in the axilla. Okay, there will be numbness and paresthesia in the axilla. There will be phantom breast syndrome. Long thoracic nerve, there will be winging of the scapula. Then most common complication is seroma. Seroma is the most common complication. Then lymphedema, that is post-mastectomy of the upper lymphedema. This long-standing lymphedema, almost about 10 years, after 10 years it can lead to lymphangiosarcoma. So this is also known as Stewart-Travis syndrome. Okay, next complication is recurrence. In diabetic foot, we have to learn the grading system. Okay, grade 1 is initially there will be a superficial diabetic ulcer. superficial diabetic ulcer. In grade 2, there will be a deep diabetic ulcer. Okay, deep diabetic ulcer. In grade 3, there is diabetic ulcer with abscess or osteomyelitis. There is that deep ulcer with abscess or osteomyelitis. In grade 4, there is gangrene to a portion of the foot. There is gangrene to a portion of the foot. Then grade 5, there is extensive gangrene. Okay. And in grade 3, it requires surgical debridement and IV antibiotics. It requires surgical debridement and IV antibiotics. In this case, it requires only oral antibiotics. Okay. In stage 0, the skin above the organ is normal. The skin above the sole is normal. Okay, there is no any ulcer in grade 0. Okay. In grade 4 requires only requires only ray amputation. Okay. Then if it is grade 5, that is extensive gangrene, it requires below-knee amputation. Okay. So this is about the grading of the diabetic foot and its management. Staging of the TB lymphadenitis. Okay. First stage 1 is firstly there will be only many lymph nodes. Okay, there is many lymph nodes that is not mated. Okay, that is not mated. Okay. Next, in the second case, there is mating of the lymph node, and here cassation will start. There is mating of the lymph node is there, and also it will it get fixed to the surrounding tissue. In the stage 3, there is central softening due to the soft tissue due to abscess formation. There is central softening due to the abscess formation, and there is progressive cassation necrosis. Okay. In stage 4, there is collar stud abscess form. There is collar stud abscess formation. That is skin over is inflamed and there is rupture of the cassation material. Skin is inflamed and there is rupture of the cassation material. In stage 5, there is sinus tract formation. There is sinus tract formation. So in grade 1, there is just only lymph node. Only lymph node is there. Okay. In stage 2, this lymph node will get mated and also it will get fixed to the surrounding structure. In stage 3, there is abscess. There is softening of the center. There is abscess formation. There is abscess formation. The next stage, there is the surrounding skin is inflamed and there is rupture of the cassation material. There is rupture of the cassation material. Then in the next is there is sinus tract formation. There is sinus tract formation.